Bismillahirrahmanirrahim. The quote of the day is a warm smile is the universal language of kindness. Today the topic of presentation is herpes under the kind supervision of Professor Dr. Saira Afzal. The learning outlines of today's presentation is the causative agent, global burden, clinical presentation, diagnosis, treatment, prevention, complications of genital herpes and herpes labialis. The case presentation of a genital herpes. A 32-year-old male had multiple sexual partners. He developed grouped vesicular lesion on his genital area at the age of 30 years for the first time in his life. He was advised antiviral treatment for 10 days, after which he recovered from the symptoms after 12 days. Later, he again developed the same lesions on the same site but of less severity for multiple times, for which physician advised him to take antiviral medicines daily. The lesions first looked like vesicles, then open blisters, and then crust, but no scar formation. These are the initial lesions which are formed on the genital region that are the vesicular in nature, are the blisters. And later on these lesions burst up, the blister burst and they form the crust. Now the introduction. Infection with herpes simplex virus known as herpes is common globally. It has two types, herpes simplex virus type 1 that is transmitted from oral to oral contact and it causes oral herpes, also called uh, it is also called herpes labialis, while herpes simplex virus 2 is transmitted via sexual contact and it causes genital herpes. Both are mostly asymptomatic or unrecognized but can cause painful blisters or ulcers at the site of infection, ranging from mild to severe. Infection is lifelong and symptoms can reoccur over many years. Some medications are available to reduce the severity and frequency of symptoms, but they cannot cure the infection. No herpes simplex virus 1 problem statement. In 2016, the last available estimates that are available, 3.7 billion people under the age of 50 years or 67% of the population, world population had herpes simplex virus 1 infection, that is maybe oral or genital, and most herpes simplex virus infections are acquired during childhood. People who already have herpes simplex virus 1 are not at risk of reinfection, but they are still at the risk of acquiring herpes simplex virus 2. No herpes simplex virus 1 symptoms and signs. Oral herpes infection is mostly asymptomatic. These are called cold sores or herpes labialis. Symptoms can include painful blisters or open sores that are ulcers in or around the mouth. Infected persons will often experience a tingling, itching, or burning sensation around their mouth before the appearance of sores. The presentations are shown in the figure. As I previously explained, first the blisters are formed and then the blisters open and then form crust, but no scar formation in it. Now these are the stages how the virus changes its shape, changes its presentation from initial to later stages. No herpes simplex virus 2 problem statement. Genital herpes that is caused by herpes simplex virus type 2 affects at an estimated 491 million, about 13% of the world population of aged 15 to 49 years from the 2016 available data. Its high prevalence in the Africa. Genital herpes symptoms. The incubation period of genital herpes is 5 to 14 days after the sexual contact, and then there is the initial episode that resolves within 2 to 3 weeks, and then there is a latent state in which the virus travels to the nerves and remains inactive and do not cause any symptoms. Then there is the recurrent episodes. Before the recurrent episode, 50% of the patients experience the prodrome symptoms. The prodrome symptoms are that in which the patient experiences itching, tingling, or pain in buttocks or legs or hips before the appearance of the rash. In recurrent episode, virus travel through the nerves to the skin surface, and the triggering factor for these are illness, stress, sunlight, and fatigue, and menstrual periods in the females. Now, this is how virus uh, uh, completes its stages. First, when the virus is in the skin, it travels to the nerves where it will remain latent for a while, and then when the triggering factors occur, they again travel to the skin and cause the disease. No genital herpes clinical presentation. The initial episode. First herpes outbreak is the most severe and symptoms tend to be most severe. Blistering or ulcerative lesions on the external genitalia. Systemic symptoms that may occur are fever, headache, malaise, and myalgia that usually in the first 3 to 4 days. The local symptoms may be pain, itching, dysuria, vaginal or urethral discharge, and tender inguinal lymphadenopathy. The first episode. The first episode is can be the primary in which the person is seronegative for herpes simplex 1 and herpes simplex virus antibodies occurring after an incubation period of 5 to 14 days after sexual contact. An initial episode refers to individuals who have the lesions for the first time but already have antibodies to herpes simplex virus 2, indicating that the past asymptomatic acquisition of herpes simplex virus type 2 has occurred. Although this would be the person's first recognized episode, it would not indicate recent acquisition. No examiner findings that are the signs. In herpes simplex, the pathognomic sign is the group vesicular lesions that are a group or cluster of vesicopustular or ulcerative lesions that is observed on the external genitalia and usually used as a clinical indicative of genital herpes. As shown in the figure, that these are the group vesicular lesions. These are not scattered, they are confined to a circumscribed region. These started as papules or vesicles and that spread rapidly. Multiple small vesicular lesions may coalesce into large ulcers. Since the ulceration of herpes is shallow, that are confined to the intraepidermal region of the skin, that is the uh, topmost part of the skin, and the residual scarring from these lesions is uncommon. These are the initial stages when the blisters are present, and these are the late presentations when there is scarring, uh, crusting. Or when a person has a typical appearance of a crop of vesicles or gives a history of recurrent ulcers, a presumptive diagnosis of genital herpes can be made and treatment tailored appropriately. Among immunosuppressed individuals, these ulcers may persist and continue to expand laterally and superficially for a considerable period of time if not treated. Now, the recurrent genital herpes. Recurrent genital herpes tend to be milder than initial outbreak, tends to have more localized symptoms in which there is itching, recurrent ulcers, and mild pain. Duration of the episode averages between 4 to 5 days, but may be as long as 12 to 15 days. Now, the transmission of herpes simplex virus type 2. The herpes virus is the most often transmitted between the partners during oral, anal, or vaginal sex. The risk of spreading the infection is much greater when a person has signs or symptoms of the active infection, but it is still possible to spread the infection even when the ulcers are not present or the patient is asymptomatic. It is also possible for a person to develop genital herpes after exposure to cold sore or an infected person lip during oral sex. In this case, genital herpes most likely due to infection with herpes simplex virus type 1. The risk of transmission from an infected male to an uninfected female partner is higher than the risk of transmission from an infected female to an uninfected male partner. No pregnancy during herpes during pregnancy. Women who have their first outbreak of genital herpes near the time of their delivery are at increased risk of transmitting herpes to their newborn. Pregnant women with symptoms of genital herpes should inform their healthcare providers. Preventive antiviral therapy with acyclovir is often recommended for women with one or more recurrences during pregnancy. A C-section delivery is usually recommended in women who experience an outbreak at the time of labor. No genital ulcer disease syndrome. As the differential diagnosis of the genital herpes are the tapinoma pallidum that causes primary syphilitic cancer, and chlamydia trachomatis that causes lymphogranuloma venereum, and Haemophilus dysorbi that causes chancerite, and they all present and they have same clinical picture. So it is difficult to diagnose on the clinical picture. So WHO recommend to tailor the treatment according to the genital ulcer disease syndrome. In this, they describe that the relative prevalence of positive organism for genital ulcer disease varies considerably in different parts of the world and may change dramatically over time. Currently, however, herpes simplex virus 2 and herpes simplex type 1 have become the commonest causative agents of genital ulcer disease in many parts of the world. As shown in the figure, many of these genital ulcers look the same, so it is difficult to identify that these genital ulcers are caused by which organism. Towards the diagnosis. Based on individual medical history, their signs and symptoms, and the result of tests, differential diagnosis of genital ulcers using clinical judgment has been shown to be inaccurate in over 50% of cases, even by the experienced clinicians. Management of people with genital ulcer disease must be based either on the Laboratory-based etiological studies are a syndrome approach guided by a periodic evaluation of the causative agents at the local setting. No laboratory diagnosis of the genital herpes that is commonly done by the three tests. First is the molecular testing, in which the polymerase chain reaction of the herpes simplex virus DNA from swabs of the genital lesions, and that are the blisters or the open blisters or the crust, is the most sensitive and specific test. Using a combined herpes simplex virus and treponema pallidum PCR when available would be of added benefit to implicate or exclude syphilis at the same time. PCR assays have also been developed for type 1 and type 2. Know the culture, blood culture, ulcer culture method. Culture enables replication of the virus for determining resistance to antiviral therapy and for confirming diagnosis, but results take about 2 to 4 days. Detects the virus in only about 50% of the cases. The culture is most likely to detect the virus when ulcers are new and open as compared to when they are older and healing. Parasitic lesions give the lowest yield, more sensitive in individuals experiencing an initial episode than in individuals experiencing a recurrent episode. Now the serology that is by, done by the blood. It is used when a person has no visible ulcer but has a history of genital ulcers in the past. Having a positive test for these antibodies indicate that a person was infected with the virus at some time in the past. Antibody testing may be negative early during the initial episode of the infection since the antibody formation takes a few weeks. The antibody test remains positive for life. Routine screening for herpes simplex type 1 and type 2 is not recommended. Blood tests may be helpful for couples if one person has a history of genital herpes and the other have not. If the partner have not been infected, then it is important to discuss ways to prevent transmission. Type-specific antibody tests can distinguish between type 1 and type 2 and help to predict the likelihood of future recurring, given that type 2 recurs more frequently than type 1. Now, this is the flow chart for the management of genital ulcer disease. This is the flow chart. When the person have the symptoms of the genital ulcer, take medical and sexual history and assess the risk of sexually transmitted infections. Do a physical examination of the genital and anal areas, and if the sore or ulcers are present, if they are present, re resources and capacity for molecular assays that are for the PCR are available, then perform test. And if the test results are available on the same day, then uh, and if the test is positive for herpes simplex virus or for syphilis, then treat based on the test results on the same day, and also offer the patient with HIV and syphilis testing and other preventive services. And if there is limited or no laboratory capacity, then ulcer vesicular or history of recurrent ulcer in the same site. If it is present, then treat for herpes simplex virus, and if the history of recent syphilis treatment for the past 3 months, uh, and if it is not present, then treat for syphilis, and if it is present, then offer HIV and syphilis testing. And if the sores or ulcers are not present, then offer HIV and syphilis testing and other preventive services. No treatment of genital herpes. For recurrent infections, there are two treatment options available. First one is the episodic treatment and the other is the suppressive treatment. Now, what is the episodic treatment? It is a strategy of taking antiviral medicines only when the outbreak occurs, while in suppressive treatment, antiviral treatment that is taken every day to prevent outbreaks for a long period of time. Episodic therapy, it decreases the duration and severity of the illness but does not reduce the frequency of outbreaks, while the suppressive therapy decreases the frequency and duration of recurrences and while also reduces the risk of transmitting herpes simplex virus. For persons with recurrent ulcers that are too frequent, for example, more than 6 episodes in a year, or with severe symptoms or causing distress, suppressive therapy may be proposed and preferred to episodic treatment, and people receiving suppressive therapy may be assessed after 1 year and asked whether they want to continue or change to episodic therapy. Now, these are the treatment of the genital herpes. These are the first-line antiviral medications that can be used for the primary infection in which the infection is occurring for the first time. Then the acyclovir 400 mg is given thrice daily for 10 days, and if it is a recurrent infection and the episodic therapy is given, then acyclovir 400 mg is given thrice daily for 5 days. And if it is recurrent infection and suppressive therapy is given, then acyclovir 400 mg is given orally twice daily for a long period of time. Now the prevention. Symptoms of oral herpes. Uh, if you have the symptoms of oral herpes, then avoid oral contact with others, including oral sex and sharing objects that touch the saliva. Symptoms of genital, if you have the symptoms of genital herpes, then abstain from sexual activity while experiencing symptoms. Both type 1 and type 2 are the most contagious when sores are present, but can also be transmitted when no symptoms are felt or visible. For sexually active people, consistent and correct use of condoms is the best way to prevent genital herpes and other sexually transmitted infections. However, herpes simplex virus infection can still occur through contact with genital or anal areas not covered by the condom. Medical male circumcision can provide lifelong partial protection against type 2 infection as well as against HIV and human papillomavirus. People with symptoms suggestive of genital herpes should avoid HIV testing. Know the complications that can arise after the herpes simplex infection. Type 2 infection increases the risk of acquiring HIV infection by approximately threefold, and additionally, people with HIV and herpes simplex 2 infection are more likely to spread the HIV infections. Herpes simplex type 2 infection is amongst the most common infections in people living with HIV. Know the severity of the disease. In immunocompromised patients and with advanced HIV infection, herpes can have more severe symptoms and more frequent recurrences. Rare complications of herpes simplex type 2 include meningoencephalitis and disseminated infections, while with the type 1 is can lead to encephalitis or keratitis and neonatal herpes. It is a serious condition that can lead to neurological disability or death. Now, what's new? Recent time for the recent updates. This is the first article in which the title of the article is polyethylene glycol coated zinc oxide nanoparticle, an efficient nano weapon to fight against herpes simplex virus type 1. The aim of the study is to determine the possible inhibitory effects of zinc oxide nanoparticles and polyethylene glycol coated zinc oxide nanoparticles on herpes simplex type 1. The Materialism Method is that pegylated zinc oxide nanoparticles were synthesized by the mechanical method. Antiviral activity was assessed by 50% tissue culture infectious disease and real-time PCR assays. To confirm the antiviral activity of the zinc oxide nanoparticles on expression of type 1 antigens, in-depth immunofluorescence assays were conducted. The result is that 200 microgram per ml of zinc oxide pegylated nanoparticles could result in 2.5 log 10 uh, uh, tissue culture infection dose reduction in virus titer with inhibition rate of approximately 92% in copy number of herpes simplex virus genomic DNA. The conclusion is that pegylated zinc oxide nanoparticles could be proposed as a new agent for efficient herpes simplex type 1 inhibition. Our results indicated that pegylation is effective in reducing the cytotoxicity and increasing antiviral activity of the nanoparticles. No, this is related to the vaccination of the herpes simplex virus. The title is Immune Response to Herpes Simplex Virus Infection and Vaccine Development. Now, what prophylactic vaccines? Prophylactic vaccines for HSV are needed to effectively stimulate primary immune response at the site of pathogen entry. Among the naive T cells, the dendritic cells are the important cell type for stimulating naive T and B cells, and this stimulation subsequently leads to the protection of uninfected host. Then is the immunotherapeutic vaccines that are also important for reduction in herpes shedding and alleviating herpetic disease in symptomatic patients with recurrent outbreaks. The challenge is that it is the uncertainty of the humoral and cell-mediated responses induced by herpes simplex virus vaccine candidates to confer lasting protection. Furthermore, the development of vaccine candidates that can confer protection against both type 1 and type 2, for example, in the case of genital herpes, remains a channel. Different promising vaccines are already undergoing testing or have completed testing. Now the turn for the MCQs. First MCQ is a newly married lady has some sort of lesions on her genital area for some days. On history, you reveal that her spouse got infected by genital herpes few months ago. On clinical examination, how will you rule out herpes simplex virus type 2 from other diseases causing genital ulceration? Whether from pus coming out from the urethral meatus, vesicular ulceration on other parts of the body as well as like lips, face and hands, or from grouped vesicular lesions on vulva, or from painless firm round and small nodule on vagina, or from painful red colored bumps in the genital region that become ulcerated.
C.
Yes, C is the correct option. As the clinical sign of the herpes simplex type 2 is the group vesicle lesions on the genitalia. Second MCQ is 20 years old lady contracted genital herpes. Various antiviral drugs are available to treat herpes simplex virus type 2. Which option is not correct regarding the treatment of genital herpes? That there is no cure for herpes or infection once gives a lifelong immunity. Antiviral medications can prevent outbreaks. Antiviral medications can shorten the outbreaks, or antiviral medications can prevent uh, transmission.
Alpha.
Which is not correct. Infection once gives a lifelong immunity. Once the infection occurs, there are many chances of the recurrence of the disease. So beta is the correct option. Regarding it is not correct. Third MCQ is a 16-year-old girl has group vesicle lesions on her lower lip for the first time in her life for 3 days, along with itching and burning. You suspect that she got infected with cold sore. She is worried about the future sequelae of this disease. How will you counsel her? Whether it progresses to permanent scars in 40% of people, or keloid is a common complication, or it can also present exactly the same in your later life again. You can get the lesions on genital area later in your life, or vaccination can prevent recurrences.
Alpha.
Delta is the correct option, as herpes simplex type 1 can later lead to genital ulcers. While there is no permanent scars in this, only in the late stages, the crusts are formed, and keloid is not a complication, while vaccination cannot prevent recurrences. Fourth MCQ is a 20-year-old male has genital ulcer for 3 days who recently visited Thailand. He has positive PCR for HCV DNA. How will you advise her to take which precautions to control its spread to other individuals? Whether don't share utensils with anyone, wear face mask while going to public places, don't share his personal toothbrush, shaving blades, and scissors with anyone, or don't donate blood in life, or have protective sex by using condoms.
E.
Yes, E is the correct option as it spreads by the sexual contact. So protective sex is recommended to stop its transmission. Fifth MCQ is choose the correct option regarding the genital herpes in females. First option is women are affected twice as compared to men. Circumcision in males has no role in preventing transmission. Once contracted, cannot be cured with medications or vaccination. No risk of transmitting infection once the symptoms are relieved. Recurrent infections tend to be less intense and severe.
Alpha.
Yes,
A.
alpha. Yes, alpha is the correct option. A 30-year-old diagnosed case of type 2 herpes simplex has active genital symptom outbreak of genital herpes. She experienced them 7 times during the past 12 months, for uh, which are more worse which are worse, and she cannot accomplish her duties well. What is the best suitable treatment option for her? Whether he should adopt the eradication therapy or episodic therapy, palliative therapy, suppress therapy, or radiation therapy?
Beta. Episodic therapy.
Delta is the correct option, suppress therapy. If the person has more than 6 episodes in a year, or the symptoms are worse or distressing to him, then the suppress therapy, that is for long times, then the suppress therapy is advised. So Delta is the correct answer. Seventh MCQ is a pregnant lady during her 37th week of gestation developed genital herpes for the first time in her life. What medical management you will offer for this lady? Whether C-section is the preferred option for delivery, or cannot prescribe the antiviral treatment? No. A course of oral acyclovir for 10 days after delivery, or topical acyclovir twice daily for 10 days, or wash the genital area twice daily with chlorhexidine will not transmit infection to newborn. Which is the correct option?
Alpha.
Yes, alpha is the correct option. So it can prevent the infection uh, to the newborn. Eighth MCQ is a physician advise again oral acyclovir 400 mg thrice daily for 5 days to a patient who has symptom outbreak for the third time during the last 6 months. What is the advantage of episodic treatment? Whether it decreases the duration and severity of the illness, or reduce the frequency of outbreaks, or decrease the frequency and duration of recurrences, or reduce the risk of transmitting herpes simplex virus, or take it in less dose than suppressive treatment.
Alpha.
Yes, alpha is the correct option, as episodic treatment only decreases the duration and severity of the illness, while it cannot control the outbreaks or reoccurrences or transmission. Ninth MCQ is in setting where laboratory investigations are not available to detect herpes simplex type 2 infection on the same day, which management strategy is best one for a patient of a recurrent vesicular eruptions on the same site? Whether to hold the treatment for 1 day to wait for the lab reports, or continue treatment for both the herpes simplex type 2 and syphilis, or start the antiviral treatment on the same day, treat with topical antiviral initially and then with oral antiviral after the lab report, which is the correct option? C is the correct option, as the WHO recommends if the lab reports are C, Charlie. WHO recommends if the lab results are not available on the same day, don't delay the treatments, as it can lead to more severe infection. So start the treatment on the symptomatology on the same day. 10th MCQ is genital herpes tend to occur again and again if a person once got infected. What is true about recurrent infection? Whether first episode in which the person is seronegative for herpes simplex antibodies occurring after 5 to 10 days of sexual contact, are initial episodes in which person has lesion for the first time but already have antibodies to herpes simplex type 2, or tend to be more severe than the initial outbreak, or tends to have more systematic symptoms, or blister formation may follow symptoms of itching, tingling, and burning.
Alpha.
Yeah, E is the correct option. As a in recurrent infections, there is many of the patients experience the prodrome symptoms that are before the blister formation. They have itching, tingling, or burning at the site of formation of the, while the others are not correct regarding this MCQ. Uh, thank you very much for this
Okay,
for today's
thank you very much,
presentation.
Dr. Awais. Very nice presentation. Herpes is a very important topic, and we know that the spectrum of the disease that varies from the mild symptomatic or asymptomatic infection to a very severe type of encephalopathy that can be attributed to herpes virus. So the severity of the herpes can be reduced by giving antiviral therapies, and this is one of the most important preventive steps. I think the key is missing, and the second important thing is some of the MCQs has 4 options, and we have already decided that at least 5 options must be there. So please add few options where there are 4 options, and also add key in your MCQs. Thank you very much, and if anybody has any comment, please let me know. Okay, Allah Hafiz, see you next time.
Okay, Ma'am, Allah Hafiz. Thank you.